Hi, everyone, and welcome back to another episode of the All Things AFib podcast. I am honored to have the opportunity to chat with our distinguished guest today. He really is an expert in minimally invasive cardiac surgery. He's a prolific surgeon scientist with nearly 200 peer-reviewed articles. He has published some of the most impactful surgical AFib articles over the past 20 years. He's a graduate of the Sackler School of Medicine at Tel Aviv University and completed his cardiac training under the tutelage of Dr. James Cox at Georgetown University. He is the editor-in-chief of Innovations, which is technology and techniques in cardiothoracic and vascular surgery. And finally, he is currently staff at the White Oak Medical Center and adjunct professor at the University of Maryland and principal investigator of the AtriCure Cryo-ICE Trial. So thank you for joining us today, Dr. Niv Ad.
Thank you, Armin, for this kind introduction. Thank you. It's a pleasure to be here, and I'm very excited as you are.
Great. So I wanted to start our conversation today by discussing your paper, Surgical Treatment for Standalone Atrial Fibrillation in North America. And for the listeners, this was a paper that was published in the Annals of Thoracic Surgery in 2020. And really, I think there's so much to unpack in this paper. It's really full of so much great information. So maybe you can just kind of start us off by telling us why you felt compelled to specifically look at the surgical treatment of standalone AFib.
Yeah, I think that's an excellent question. I was often asked by administrators, by coders, by billing activities on one hand, and by patients and cardiologists on the other hand, of what is really going on with atrial fibrillation surgery beyond the walls of the institution I'm at. If it was before at Fairfax, where I was the chair for almost a decade, and now in this new hospital. And quite frankly, I didn't have a good answer. This is mainly because looking back and trying to recognize some of data based on North American experience, et cetera, it was lacking. The data that's coming from the industry is important, but it is designed to show one aspect or another aspect of it that may have some bias or noise in it, and so on and so forth. So we applied for a project called PAF. It's one of those projects that you pay for the data to the STS and you run your own analysis on it, specifically to look into standalone procedures for atrial fibrillation. And there were two main aims in that search when we got the permit, so to speak. The first was to understand how often it's being performed in the US or North America to that extent, and secondly, to know a little bit more of what's being done. And interestingly, the search period basically cut it kind of in the middle, because only the latest version from 2014 at the STS data in the STS database was with some details about what was really done beyond just surgical treatment for atrial fibrillations, yes or no. Now, as you know, and I hope many of our listeners, the STS is an unbelievable tool to look into outcome, complications, survival, et cetera, for 30 days, but nothing beyond that. Right. So we felt that putting out that information is going to help us to get some basic numbers, understanding on trends, and try to better understand how we can then pass this moving forward with the next papers that we want to publish and looking into outcome. Long-term outcome with rhythm, not just perioperative.
Sure. Yeah. You know what I think is really interesting is how the original Maze data, if you go back to Dr. Cox's data, that was essentially standalone data as well. And so we had years of standalone data from Dr. Cox. Then we had all this, concomitant data that came out, you know, AVR cabbage, AVR maze, cabbage maze, mitral maze, of which you've written tons of papers. And so I thought it was really interesting that we almost came back full circle to have now this standalone paper that you published in 2020. Another thing I thought was really interesting and really quite compelling is how you broke down the groups. So in your paper, you really talk about 3 groups. You talk about the on-pump maze group, the off-pump maze group, and then I thought what was really interesting was the off-pump group that required conversion. And you talk about whether that was just, you know, increasing the size of the surgical port, incision, whatever you want to call it, or actually converting to on pump with the cross clamp. Can you talk about why you thought that was an important way to break down the groups?
I think it was part of the discussion of the working group among us. And, you know, on one hand, we have a surgical procedure that we know, all of us that are dealing with it, whether you do it one way or another, it's much more effective than a single or double catheter-based procedure and so on and so forth. And there is a lot of information on the safety of those procedures by the cardiologists, by the EPs, especially, you know, a famous paper by our good friend Hugh Calkins from Johns Hopkins that actually set I think the foundations for that. So we felt that there is the first question is whether it's safe or not. And the general answer was yes, but then we recognized that noise, that was a blip of what we want to say less than expected or disappointing outcome, which has some major complication associated with it. Now, the point is that it's always important to show it to others and say, listen, anything we do can have consequences. But on the other hand, what we felt is important is to communicate with surgeons that surgical treatment for atrial fibrillation is not a side job. Like, no one there to do off-pump cabbage or on-pump cabbage unless they are, you know, proficient in it. But we felt that in AFib especially, this kind of unwritten rule that we have among us cardiac surgeons with the responsibility and commitment to surgeons broke to some extent. So we felt that it's important to actually communicate with our community and others that if off-pump procedures or on-pump procedures are being done wrong, there are major consequences to it. And then comes all the interpretation, you know, are you in this group or in that group? But I can tell you, this was actually the way we looked at it moving forward. We wanted to set the foundations that we can actually look and say, okay, look, in 2017, there were a 6% conversion rate with mortality of X. And in 2021, we had only 3% conversion rate. You know, so I think it's important for the progress of the field without my own opinion or your opinion or anybody else about what works better.
Yeah, what I thought was really interesting about this paper, I think it was a really honest, if you will, expression of what's going on in the field. So you talk about how there was an increase in the number of standalone procedures being done. There was a greater increase in the off-pump category. And then you capture this idea that maybe, and tell me if I'm wrong, that within this off-pump category, there were more centers doing these cases. They were doing less of them in general. And so it almost kind of expresses this idea that people are in this learning curve of maze surgery that they're going through in the off-pump setting, which leads to conversions. And in that population that requires conversions, they have worse outcomes. Do you think that's an honest way to kind of talk about at least the findings of growth, if you will, in the field. Do you think that's accurate?
I think that's one way to look at it, and that's a really very important description of it. I really agree with everything you said, but there is another point here that we couldn't actually pinpoint and communicate the findings in a better way. Is, for instance, how come that, let's say, over a period of a study, when you have 1,400 procedures being done every year and about 80% or more off pump, how come the conversion rate incidence didn't change? If anything, maybe even increased. And the only interpretation, and I wrote it in a very careful way in the conclusion, is that because of that phenomena, I believe that many surgeons started the procedure, had a complication, and abandoned it. So the growth that we have is not like in your center that's considered to be, one of the premier centers in the world, because you're doing it all the time, and you learn and you evolve with your technique as you know. So your chances to have a conversion now compared to 5 years ago diminish in several tenfold.
Sure.
So I think that the other important point here is to show, okay, you rush into it, you're not prepared, you have a major complication, you'll never do it again. So basically you hurt the entire field because we don't have the growth, the natural growth of procedures. As we say, well, the learning curve is something of the past. So every time we have new centers, and the learning curve is kind of a constant, it's there all the time.
Right.
And this is
right.
something I'm really bothered about.
Yeah, definitely. And I was wondering kind of how that was playing out in the numbers as well, because you talk about how before there were about 100 of these standalone AFibs surgeries happening in each center. And even though there was this growth, that number has kind of dropped down to 60 procedures being done per center. Do you think that occurred precisely because what you said? There were surgeons who were doing on pump and then tried an off pump and had an untoward complication and then stopped doing it? Or what do you think led to that decline?
Well, I think that, well, I don't know the answer, but based on the experience we have talking with our colleagues all the time, sorry, we know that there are a slew of younger surgeons that are trying to capture volume when they are in their own centers, and they are less experienced than you and I, although you are very young surgeon, but very experienced. And things I think are a combination of stuff. The other thing is that the picture I'm doing, as opposed to what you do on the basis, although I do what you guys do also, but what I'm mainly doing is the on-pump, minimally invasive, procedure is becoming less of a mainstream and an outlier now, and not so many know how to do it. So if my centers was doing, more of these before, now I'm doing less of those before because of sorts of myths and other aspects that are important of the evolution of the collaboration with the electrophysiologists, that and there are some perception about that what I do is not a collaboration versus what others are doing, and so on and so forth. So I think it's a combination of all kind of things, and also the push by the industry to open new centers, new accounts.
Right.
But when you say this way, it may reflect bad on the industry. That's not what I mean. It means that the industry is doing a great job in educating physicians, and by so doing, they basically give them the tool to open a new account, which is in the beginning of the learning curve.
Right.
And I think that's so. It's a combination. It's a process. It's an evolution of where we are.
Sure. I found at least one thing kind of reassuring between all the patient cohorts, which was this thing that we've all been battling for a long time, in kind of this common perception among either referring docs or people who don't quite understand, AFib surgery, is that at least across the groups, there was only about a 1.5% to 2% rate of new pacemaker placement. And I thought that was so important to put in the paper, because it says, look, again and again and again, doing the maze procedure, or I should say surgical ablation, does not inherently cause heart block, does not inherently require somebody to need a permanent pacemaker. I thought that was really nicely pointed out in the paper.
Yeah, I agree. So I know that I take this thing very, very seriously. So message number one is pacemakers. I think that's a myth. If you know how to do the procedures, and some of the publication, we know the procedure was not done properly, whether it's off pump or on pump, as you alluded to. So if you do it appropriately, and you know what you're dealing with, the rate is very low. Off pump procedure are extremely, extremely safe if done appropriately. That's another take-home message. If you look at the numbers for those that didn't have conversion, or when and you know that conversion can happen, but if you deal with conversion with experience, there's no reason that it's going to end up with death. Because why do we have conversion? A little hole in the appendage. So in the beginning of the experience, some surgeons that are not experienced lost patients for that. It doesn't happen anymore. So it's extremely safe. And on-pump standalone procedures are extremely safe. There's slight difference between the two groups as well. The on-pump procedure patients were a little bit higher risk than off-pump procedure patients. So it tells you that we also use judgment here, and I assume that some of those were done on-pump because someone like you said, well, off-pump is not going to help them. So I think it's a combination of things. So those are really important and positive message out of that paper. The one negative was the very low rate of appendage exclusion in the group of patients that were done off pump. But we know that this is, since the paper was published and now with LAOS and others, it's a point of emphasis to all of us. So I think this is again important to show that in 2020 or 2017 data, only 50% were appendage occluded or so, and in 2021 it's already 80, and hopefully in 2025 it will be 95 or so. Like the IMA usage.
Right. Yeah, I'm really glad you brought that up, because I was going to ask you how you think the LAOS 3 study was going to impact specifically this off-pump group. Because it was really disappointing to read that only, what was it, like 56% of the off-pump group had their left atrial appendage managed. I mean, that's unacceptable, right? So how do you think that's going to specifically affect the off-pump group?
I don't think that it's specifically going to affect the off-pump group, but I believe that it's going to affect the entire field. When I'll answer in a bit, convoluted way, but when I'm asked how many patients of mine that are coming to the operating room with atrial fibrillation I'm treating, okay? And let's say in a concomitant setup for it, but it doesn't matter. But let's say, so I say almost everyone. They say, what do you mean, close to 100%? I say, of course, close to 100%. So the next answer is, how come? I say, well, I manage their appendage almost every time unless there is a specific contraindication. And that's almost never an occurrence.
Right.
So if you look at it as a pyramid, where the basis of the pyramid, the white part of the pyramid, that's the common denominator, so to speak, is the appendage. So if you accept that concept, then you go up, I think that the appendage is basically what we do without arguing, okay? Whether to do it off pump, on pump, this, that, and the other. And I
Sure.
think the LAOS 3 trial, although it's CHA2DS2 score over 2 and concomitant and this, that, and the other, it's another brick in that consensus that the appendage is important. And therefore, moving forward, I think every surgeon going into the operating room is saying, okay, but what about the appendage? So you do Converge. There are ways to exclude the appendage. I mean, you go from the left side, you know, we don't have to go through this, but Converge also very low rate of appendage. But I'm sure that in practice every day, including your own practice, the appendage management is close to 100%. And I think that's how LAOS kind of, you know, intersect with what we say.
Right, right. Now, I'm glad you brought up Convergent, because I wanted to ask you, you know, I imagine as we progress with AFib treatment, this Convergent or subxiphoid approach will become more popular just for those same reasons that we had talked about earlier. And I'm assuming over time that there will be less conversions because it requires less, if you will, kind of technical expertise to do a Convergent than a totally thoracoscopic maze, let's say, for example. How do you think that fits in? How do you think the Convergent procedure, just doing a posterior wall isolation as in the trial, forget about kind of the Convergent plus additions, you know, managing the appendage, taking down the ligamental marshal. Where do you think that Convergent procedure fits into the spectrum of, let's say, a new surgeon who wants to treat AFib, probably doesn't have the skill set coming out of training? Do you think that's a reasonable place to start, is with a Convergent procedure?
Well, I think we need another 2 podcasts to answer. So first, I think let's talk about Converge. So Converge in general is an important aspect of our surgical ablation of atrial fibrillation, simply because that, like the FAST trial from Europe, there was a study that compared patients with persistent, long-term persistent atrial fibrillation being treated with a hybrid approach versus catheter-based procedure. And now we can say, okay, for these patients, this is how it looks, and we have some data to build on. So that's a positive. The negative part of the Converge is that, as you said, it's an easier procedure, although we know that there are some devastating complications for it if not done appropriately, but it's an easier procedure. And if you're an expert surgeon, there's no reason something will go south in that procedure. By saying that it's an easier procedure, and our tendency to define success of anything we do by the number of procedures we are doing, we are running a very, very high risk of becoming unidimensional in our treatment of atrial fibrillation. So I think the next step with Converge and understanding where Converge fits in our armamentarium is to better understand why Converge fails. How can we make Converge better if we can? And how to build a decision-making tree where you get a patient and say, this is for a bilateral thoracoscopic approach or unilateral thoracoscopic approach if you're Mark Lemaire, you know, kind of guy, but it doesn't matter, doing a clamping and so on and so forth. Or you do Converge, or you say, no, this is a full maze procedure done minimally invasively. Because we always compare those two, but remember in that paper, the STS, the vast majority of standalone procedures done on bypass were done through a mid-sternotomy.
Right.
Which is, I believe, a big disappointment for many of us, especially myself, where I almost never do a full maze procedure, not minimally invasively. There are a few instances that it was done, and most of the time the reason is that patients are so tired of AFib that 5-6 ablation, and all they want is something that least fancy, most forward, so to speak, with good results. So they ask for mid-sternotomy. I have a few examples of that. But the point is that I think with all the hype around Convergent and all the push of how to do it and all those kind of things, we have to be really, really careful to maintain what we have, and which is the patient's interest, to be able to offer them something nobody else can offer them, which is cure from atrial fibrillation. Whether you do it, but you have to keep these three options alive. So I think it's on all of us to better understand that procedure.
Right. What I'm hoping for personally is that at least Convergent introduces surgeons to this idea of treating atrial fibrillation seriously, and maybe it acts as a trigger for them to do more open concomitant cases, and then to ultimately kind of take that practice curve, learning curve, progression, if you will, to become a more serious AFib surgeon, and then ultimately kind of treat more atrial fibrillation. Because we know, we've been talking about standalone, but we also know there's a huge deficit of treating atrial fibrillation in the CABG patient, in the AVR patient. It's a little bit better in the mitral patient, but I'm also hoping that the Convergent procedure can at least start to entice or introduce people into better treating atrial fibrillation in the open setting as well. Let's change gears a little bit here, unless you want to comment on that.
I agree with everything you say, and the point is that the most important aspect of how we define an outcome of a procedure should be actually push for elimination of the 30 days outcome from AFib surgery. I think it's going to give us, imagine that patency rate was judged only by 30 days outcome for CABG versus PCI. Nobody would do CABGs anymore.
Right.
But we know that when you go to the second, third, and definitely the fifth year, this is where you start to see the definition. So that's one thing I want to see. The second thing I want to see is, even if you do a full MACE procedure, don't look at it as the only solution you're offering to the patient. Patients that fail should go to the cath lab for the EP lab to see why they failed. They didn't fail because they have atrial fibrillation for 6 years. They fail because patients with longer duration of atrial fibrillation have a most challenging substrate, and applying lesion is more difficult, especially consistent lesions. So I think we have to start, to think this way about how we move the field forward. Let me just give you one. I know we need to jump to the other one, but one story. Why did I start my huge database? We did 117 cases, and we wanted to look at the six months results. This is when we started Fairfax. This was the first 117 cases. I remember the number. And we had about, within the blanking period, we had about 24% of any event that you see once or one way or another. And some patients remained with a so-called persistent event. So when you ask yourself, how many of these patients were cardioverted? Okay, the answer was amazing. I thought all of them were cardioverted, but only less than 20% of them were cardioverted. When you go to the EP patient with a catheter-based procedure that have a recurrence that is more persistent at 3 months, 100% of them are being cardioverted. So there is a separation of, it's a MACE procedure in a CABG patient. If he's back in AFib, it's not as interesting if you had the non-procedure. So we'll never take you back to the EP lab. And I think that's another step moving forward.
Absolutely. And I think that's a good segue into your CryoICE trial. So can you tell us a little bit about how you think CryoICE will help our field, how it will, I guess, add another layer to our tools? Can you talk a little bit about CryoICE and why you thought that was a study that had to happen now?
Well, first, it's an FDA trial, so it's being basically designed to approve the cryo platform that's specific for that trial, and make sure that it's indicated for atrial fibrillation in a concomitant setup. What does it mean, indicated, for our listener? Today, the cryo platforms we are using from two companies, it doesn't matter, it's the same indication, kind of. It's tissue ablation or cardiac ablation, but not specifically to treat atrial fibrillation. This is huge ramification when we go out to train, huge ramification when we go out to educate, huge ramification when we want to highlight the importance of how to treat atrial fibrillation in the setting of coronary disease, which for our listener, if you look at the Medicare data, not at the STS data, it's less than 20%. Less than 20% of patients with atrial fibrillation coming from CABG are having surgical ablation. And the STS is a little better, but it's mid-20s, only mid-20s. So I think that's the one aspect of it. The second aspect of it, that we will be able, in a very controlled trial that's being done prospectively and so on and so forth, to show that the addition of the cryo machine, ablation and so on and so forth to any concomitant procedure is not going to be associated with increased morbidity related to the index procedure. Meaning that if you do a mitral valve, we do a mitral valve maze, you have that. And I think the other aspects that we are going to find out is, which we felt very important, is right now it's pretty much an open field. Oh, I freeze for 1.5 minutes, you freeze for 3 minutes, the other one freezes for 5 minutes, almost
Right.
like the same way with the amp. I do 10 times, you do 2 times, and so on and so forth. We have basically under control trial, we have the setup of what we think is going to work, which is 3 minutes on the left, 2 minutes on the right. And this can be like, a building stone. So now to see, you can come on and build on it and compare it to something else. Is it better or not? So I think those three aspects are very important. The other aspect that's very important is that we don't have only academic centers in the trial. We don't have like partner stuff. We don't have those big giant academic centers. We have big giant academic center, but we have small centers like mine and yours that are taking part of it, and Mark Gerdish and others that are very active in it. So we are going to basically have a picture reflecting, what's being done in America today for concomitant procedures in various levels of surgeon centers and so on and so forth.
Right. I think one thing that I think is super important that you pointed out was the indication for atrial fibrillation, because it seems like, we've all taught these courses. It seems like there is a gap in education, whether it's your resident who just finished training, the junior surgeon, even some of the seasoned surgeons out there in the field. There is this gap of why do we treat AFib? How do we appropriately treat atrial fibrillation? What tools are available to treat it? And what are the results? Even though we have all this data saying it's undertreated, and we have some studies that came out recently that tell us that, managing left atrial appendage, things like this are super important. There does seem to be this gap in knowledge. And I think getting that indication with these specific approaches, if you will, with cryo, will help us get out there and educate more and more and more, and hopefully just make the whole field more aware and more comfortable with treating atrial fibrillation. For the listener out there,
I could agree.
Do you have a sense of when you may finish enrollment and when we could possibly see results from this trial?
I have a sense. I think we are fairly close. Probably within the next 6 months, we'll finish enrollment. Depends on the interim analysis. Like all studies, the COVID really hurt us with enrollment.
Sure.
But now we are enrolling in a pretty good pace.
Okay.
So we hope to finish enrollment. We are close to about 70%. So we are moving along. We put you on, as you know, a few weeks ago. So you and some other two new centers that are about to start enrolling, I think, will help us tremendously in this, and we will be able to finish enrollment, and then obviously we need all patients to be followed for a year before we embark with final results. So fairly shortly, we will have some type of information about it.
Gotcha. So we're hoping maybe, I guess, fourth quarter of 2022 or first quarter of 2023. Maybe that's something we could all be looking forward to.
Yeah, I think if we enroll the last patient, let's say during the second quarter of this coming year, 2022, then next AATS May, I mean the one in 23, we will be able to present the data or something like that. I mean, that's wishful thinking, but you
Sure.
know how it goes. It's an
Yeah.
FDA trial, it's adjudicated, and
Right.
and all those kind of things. But I think we'll have some good sense of what's going on. I can tell you so far what we see from the reports of the DSMB and the CEC. It's going fairly well.
That's great.
And safety is definitely within what we were expecting.
That's wonderful. That's wonderful. Well, I'm sure we're all going to be looking forward to those results. Is there anything else you'd like to touch on? You know, we touched on the standalone, we touched on the CryoICE. Is there anything else you'd like our listeners to hear from you specifically before we finish up this session?
Yeah, I think one thing, you know, going back to the so-called science of atrial fibrillation or the clinical aspect, I think that the LAOS 3 trial taught us that the appendage is important, but it also taught us that the appendage is not enough. Because if you look at any other big series of concomitant procedures for atrial fibrillation, mine and others, the stroke rate at 5 and 10 years is probably not beyond 1%. So it's not the same as in a trial like that. So maybe it's a little higher and we miss some here and there, but it's definitely not 4% at 3 years. So AFib ablation is remaining really important, and the appendage, the LAOS trial showed me at least that the appendage is important, but it's not the only thing that's important if we're talking about it. So that's one thing. The second thing, for patients that may be listening, you know, do your research and you know, and seek for, if there is a need after at least after a couple of failed ablation and you are highly symptomatic, seek for some good advice from surgeons that are experienced in the field. Not necessarily go and shop to do the procedure there, but even if you don't feel like you are someone that should have the procedure, go and speak with a reasonable surgeon that is doing it for many years, like in your center, like in our center, like in others that are all over there, and get their opinion about where do you stand. Don't just accept this. Disease can be very, very devastating. Symptomatically, stroke risk and medication and so on and so forth.
Right. Absolutely. You know, it's interesting what you just said kind of reminds me of what happens in the mitral repair world, right? We have data that says if you can perform an excellent mitral repair, it's better than replacement. But a bad mitral repair is not as good as replacement. I find we're almost in that same space with atrial fibrillation. You know, surgeons who can treat atrial fibrillation appropriately, they can provide a really effective treatment for atrial fibrillation. If you end up going to a surgeon who's not experienced, who has conversions, who has complications, then you don't get the result that you're looking for. You know, kind of very similar to that mitral repair, mitral replacement population.
Yeah, I think that's absolutely the point. The other point, I can see it almost in every aspect of atrial fibrillation surgery. I'll never take a patient, okay, to surgery if I don't truly believe that based on my experience, I can help the patient. Again, this is a procedure that is provided to the patient to improve their quality of life and reduce the risk of devastating complication in the future. But that's not an imminent threat right this moment when they see it's not a left main disease or severe mitral insufficiency with low EF, the ejection fraction, and so on and so forth. So our responsibility to give patients good advice is really important. So when I tell a patient, listen, if I were you, I wouldn't do the procedure. I wouldn't have the procedure, not mine and not that one or the others, and so on and so forth. I think that's an important message to patients. And at the end of the day, they will benefit from this advice because they can then maybe decide to have a Watchman and a AV nodal ablation.
Right. And
even
I think
though
that
they didn't think so, so we have this responsibility, I think. And patients should not be shy, of coming to us, that to get this kind of advice.
Right. And I think it goes back to something you said earlier, which I thought was very keen, which was we shouldn't be judged on our success of atrial fibrillation by how many procedures we do, but rather the quality of the procedure and the outcome for the patient. So at the end of the day, it's about going to a surgeon who's experienced, but also has the outcomes to back up that surgical volume. So Absolutely. Well, thank you so much for your time today. That was a wonderful conversation. I'm sure we're going to do another episode before your CryoICE results come out. But until that time, I really hope we can do this again.
Okay. Thank you, Armin. It was great to be with you. As usual, you show how much you know about the field. I know you're an excellent AFib surgeon as well. I watch you operating, and it was a real pleasure of mine. And good luck with our podcasts, and it's really important. And I feel honored to be your guest today.
Great. Thank you, Dr. Ad. Thank you so much.
Thank you. See you. Bye-bye.
Bye now.